Myasthenia gravis. Introduction. It's an autoimmune disorder and is the most common disorder of neuromuscular transmission, resulting in reduced muscle strength and a reduced capacity for repetitive muscle use. Fluctuating motor weakness is seen in the ocular, bulbar, limb, and respiratory muscles. The weakness is due to an antibody-mediated immunologic attack directed at proteins in the postsynaptic membrane of the neuromuscular junction, acetylcholine receptors, or receptor-associated proteins. It occurs at any age, but there tends to be a bimodal distribution to the age and sex predominance of onset, with an early peak in the second and third decades, female predominance, and a late peak in the 6th to 8th decade, male predominance. In neonates, a transient form of myasthenia, called neonatal myasthenia gravis, can occur as a result of the transplacental passage of maternal antibodies that interfere with the junction of the neuromuscular junction. Pathogenesis. 80 to 90% of patients with myasthenia gravis have autoantibodies against the acetylcholine receptor detectable in serum, and these antibodies are believed to play a central role in pathogenesis. At a cellular level, acetylcholine receptor antibodies cause dysfunction at the neuromuscular junction by blocking acetylcholine receptor binding to the acetylcholine receptor, cross-linking and internalizing acetylcholine receptors, and activating complement-mediated acetylcholine receptor destruction. The acetylcholine receptor antibodies in myasthenia gravis are primarily immunoglobulin G1, immunoglobulin G3. Some patients with myasthenia gravis who are seronegative for acetylcholine receptor antibodies have antibodies directed against another target on the surface of the muscle membrane, muscle-specific receptor tyrosine kinase. Muscle-specific receptor tyrosine kinase autoantibodies are commonly seen in 40 to 70% of patients with acetylcholine receptor seronegative myasthenia gravis, especially from Europe and Japan. Patients with both muscle-specific receptor tyrosine kinase and acetylcholine receptor antibodies are uncommon, although the frequency may be as high as 10% in some regions in Asia. In contrast with acetylcholine receptor antibody-positive myasthenia gravis, in which complement-fixing immunoglobulin G1 and immunoglobulin G3 subclasses predominate, muscle-specific receptor tyrosine kinase antibodies are mainly immunoglobulin G4, the immunoglobulin G subtype that does not activate complement. Role of T cells. T lymphocytes also play an important role in myasthenia gravis. T lymphocytes bind to the acetylcholine receptor, and their main role is thought to be stimulation of B-cell antibody production. The thymus and the origin of autoimmunity. The majority of patients with acetylcholine receptor antibody-positive myasthenia gravis have thymic abnormalities. Hyperplasia in 60 to 70% and thymoma in 10 to 12%. However, the disease often improves or disappears after thymectomy. As a result, the thymus has been evaluated as a possible source of antigen to drive this autoimmune disease. Genetic factors. Genetic factors also contribute to the pathogenesis of myasthenia gravis. Certain human leukocyte antigen types have been associated with myasthenia, including human leukocyte antigen B8, DRW3, and DQW2. Muscle-specific receptor tyrosine kinase antibody-positive myasthenia is associated with haplotypes DR14 and DQ5. In addition, patients with myasthenia frequently have other immune-mediated diseases, such as systemic lupus erythematosus, rheumatoid arthritis, Graves' disease, and thyroiditis, and a family history of autoimmune disorders. Other factors. One important point that needs to be noted here is that acetylcholine receptor antibody levels do not clearly correlate with the severity of myasthenia gravis. Therefore, researchers have identified additional factors, for example, other muscle antibodies, secondary cytokines, chemokines, that might positively correlate with the disease. As examples, the chemokines CXCL13 and CCL21 are overexpressed in the hyperplastic thymus from individuals with myasthenia gravis and may play a pathologic role in the recruitment of lymphocytes to the thymus. Classification. The clinical manifestations of myasthenia gravis can vary from mild and focal weakness in some patients to severe tetraparesis with respiratory failure in others. Clinical forms. There are two clinical forms of myasthenia gravis, ocular and generalized. In ocular myasthenia gravis, weakness is limited to the eyelids and extraocular muscles. In generalized myasthenia gravis, weakness involves a variable combination of ocular, bulbar, limb, and respiratory muscles. Many patients with ocular myasthenia gravis eventually progress to generalized myasthenia gravis. Symptom severity. Myasthenia gravis may be categorized by symptom severity to guide treatment decisions. A widely used classification system from a task force of the Myasthenia Gravis Foundation of America stratifies patients by the extent and severity of muscle weakness. Class 1. Isolated ocular muscle weakness. Class 2. Mild generalized weakness involving non-ocular muscles. Class 3. Moderate generalized weakness involving non-ocular muscles. Class 4. Severe generalized weakness involving non-ocular muscles. Class 5. Intubation due to respiratory muscle weakness. Clinical manifestations. Myasthenia gravis is characterized by skeletal muscle weakness that fluctuates over the course of a day. Neuromuscular weakness. The hallmark feature of myasthenia gravis is skeletal muscle weakness, often with true muscle fatigue. Muscle fatigue is characterized by worsening contractile force of the muscle, not a sensation of tiredness. Fatigue without weakness is inconsistent with myasthenia gravis. Patients present with complaints of specific muscle weakness and not generalized muscle fatigue. Muscle weakness may occur in any muscle, but most frequently affects ocular and other bulbar muscle function more than other muscle groups. Ocular function. Ocular symptoms are the most common in myasthenia gravis and may include ptosis due to weakness of levator palpebral muscles and diplopia due to the weakness of extraocular muscles. Symptoms are frequently asymmetric. The diagnosis of ocular myasthenia gravis is suggested by the triad of ophthalmoparesis, ptosis, and orbicularis oculi weakness. However, isolated ptosis and ophthalmoparesis are also common presentations. Demonstrating fatigue in the ocular muscles is a helpful but not infallible diagnostic sign for ocular myasthenia gravis. The pupillary function is spared, helping in the differentiation from other ocular disorders. Ptosis. Weakness of the eyelid muscles can lead to ptosis, the degree of which can be quite variable throughout the day. It may switch from one eye to the other over time. Ptosis may start unilaterally and then become bilateral, or may start bilaterally and improve in one eye, resulting in unilateral ptosis. At times, it may be so severe as to occlude vision. Curtain sign. Lifting the more ptotic eyelid reveals ptosis in the contralateral eyelid. Kogan lid twitch sign. The patient is asked to gaze downward for 10 to 20 seconds and then to look straight ahead. The affected upper eyelid briefly twitches. Simpson test. Provocation test used to reproduce eyelid fatigue. Positive if looking upward for more than 1 minute without lifting the head provokes eyelid fatigue. Ice pack test. In patients with myasthenia, ptosis typically improves after the application of ice to the upper eyelid. The sensitivity of this test is approximately 80% in those with prominent ptosis. It's generally not helpful for those with other ocular symptoms, such as extraocular muscle weakness. Diplopia. Weakness of the extraocular muscles produces binocular diplopia that disappears when the patient closes or occludes one eye. It may be horizontal or vertical. At the onset, this is sometimes sensed as intermittent periods of blurred vision before overt diplopia is evident. Diplopia may be identified on examination by extraocular muscle testing. Dysarthria and dysphagia. Oropharyngeal muscle weakness produces dysarthria and dysphagia. The quality of speech sounds nasal when there's weakness of the palatal muscles, or it may be of low intensity, hypophonic. These symptoms often worsen with prolonged speech. Muscles of jaw closure may also be involved and produce fatigable weakness with prolonged chewing. Dysphagia may be prominent in patients with dysarthria or masticatory weakness. Patients may be unable to swallow medications or consume adequate food or liquids. Severe symptoms with imminent risk of aspiration may produce a myasthenic crisis. Nasal regurgitation, particularly of liquids, may occur due to palatal weakness. Facial expression. Muscles of facial expression are frequently involved and make the patient appear expressionless. Family members may notice that the patient has lost his or her smell as a result of the weakness of the orbicularis oris muscle. When attempting to smile, the patient may produce the myasthenic sneer, where the mid-lip rises but the outer corners of the mouth fail to move. Neck and limb strength. Neck extensor and flexor and limb muscle weakness may be found in some patients with generalized myasthenia gravis. The weight of the head may overcome weakened extensors, particularly late in the day, producing a dropped head syndrome. Posterior neck muscles may ache due to the added effort in keeping the head up with the weakened extensors. The pattern of limb weakness in myasthenia gravis is typically proximal, and the arms tend to be more often affected than the legs. In addition, wrist and finger extensors and foot dorsiflexors may also be involved. Respiratory function. Weakness of the muscles of respiration produces the most serious symptoms in myasthenia gravis. Respiratory muscle weakness that leads to respiratory insufficiency and impending respiratory failure is a life-threatening situation called myasthenic crisis. Fluctuation of weakness. Patients typically have fatigable weakness of the specific muscle groups affected. The weakness may fluctuate throughout the day, but it's most commonly worse later in the day or evening or after exercise. Progression. Early in the disorder, the symptoms may be episodic, with asymptomatic intervals lasting hours, days, or even weeks. Over time, the manifestations typically worsen and become more persistent. Diagnosis. For most patients with clinical features of myasthenia gravis, the diagnosis may be confirmed by the presence of autoantibodies against the acetylcholine receptor or against other muscle receptor-associated proteins. For example, muscle-specific tyrosine kinase or low-density lipoprotein receptor-related protein 4. The acetylcholine receptor antibody test is the most specific test because 80 to 90% of patients with generalized myasthenia gravis have antibodies and 100% of patients with thymoma have these antibodies. Serologic testing for muscle-specific tyrosine kinase and low-density lipoprotein receptor-related protein 4 antibodies may be performed for patients with clinical features of myasthenia gravis who do not have myasthenia gravis antibodies. Look if clinical features like ptosis or diplopia or fatigable bulbar and other skeletal muscle weakness are suggestive of myasthenia gravis. If yes, perform serological testing for acetylcholine receptor autoantibodies and see if the results are positive. If yes, myasthenia gravis is confirmed. Evaluate for associated conditions, CT or MRI of mediastinum for thymoma, and assess thymic anatomy and thyroid function test for autoimmune thyroid disease. Perform serological testing for acetylcholine receptor autoantibodies and see if the results are positive. If no, perform serological testing for muscle-specific kinase autoantibodies and see if the results are positive. If yes, myasthenia gravis is confirmed. Evaluate for associated conditions as mentioned above. If no, perform electrodiagnostic testing, including the following techniques: nerve conduction studies with repetitive nerve stimulation, electromyography, and single-fiber electromyography. See if results are consistent with myasthenia gravis. Single-fiber electromyography is the most sensitive diagnostic test for myasthenia gravis. If yes, myasthenia gravis is confirmed. Evaluate for associated conditions as mentioned above. If no, perform serological testing for low-density lipoprotein receptor-related protein 4 autoantibodies and see if the results are positive. If yes, myasthenia gravis is confirmed. Evaluate for associated conditions as mentioned above. Look if clinical features like ptosis or diplopia or fatigable bulbar and other skeletal muscle weakness are suggestive of myasthenia gravis. Serological testing for low-density lipoprotein receptor-related protein 4 autoantibodies and see if the results are positive. If no, evaluate for alternative conditions. Treatment. There are 4 primary therapies used to treat myasthenia gravis. 1. Symptomatic treatment, acetylcholine esterase inhibition, to increase the amount of acetylcholine available at the neuromuscular junction. 2. Chronic immunotherapies, glucocorticoids, and nonsteroidal immunosuppressive and immunomodulatory agents to target the underlying immune dysregulation. 3. Rapid but short-acting immunomodulating treatments, therapeutic plasma exchange, and intravenous immune globulin. 4. Surgical treatment. Thymectomy. Initial therapy. Pyridostigmine. The initial therapy for most patients with mild to moderate myasthenia gravis is an oral acetylcholine esterase inhibitor, that is, anticholinesterase, usually pyridostigmine. Neostigmine is available in an oral form, but is not commonly used. Pyridostigmine is available as scored 60 mg tablets and as a liquid formulation. Pyridostigmine is also available in an intravenous preparation and can be given to patients who cannot take oral drugs. This is usually in the setting of a myasthenic crisis. The adverse effects of pyridostigmine are mostly due to the cholinergic properties of the drug. The most common side effects include abdominal cramping and diarrhea. Patients with severe disease or rapidly worsening disease should be treated much like those in myasthenic crisis using rapid therapies, that is plasma exchange or intravenous immune globulin, followed by glucocorticoids and other immunotherapies. Addition of immunotherapies. Most patients with generalized myasthenia gravis require additional therapy directed at the underlying immune dysregulation at some point in their illness, if not indefinitely. Immunotherapy is indicated for patients who remain significantly symptomatic on pyridostigmine or who become symptomatic again after a temporary response to pyridostigmine. Glucocorticoids are typically used initially, and many patients with generalized myasthenia gravis require the addition of a nonsteroidal immunotherapeutic agent, such as azathioprine or mycophenolate for maintenance and to spare long-term glucocorticoid toxicities. Thymectomy. In parallel with symptomatic pyridostigmine treatment and immunotherapeutic agents for myasthenia gravis, thymectomy is required in selected patients. In approximately 10 to 15% of patients with myasthenia gravis associated with thymoma, surgery is indicated for patients in whom complete resection is considered feasible. Thymectomy, in the absence of thymoma, is recommended in patients with generalized myasthenia gravis and acetylcholine receptor antibodies who are less than or equal to 50 years of age. Acute exacerbations. Myasthenic crisis. Transient worsening of myasthenic symptoms can be precipitated by concurrent infection, surgery, pregnancy, childbirth, certain medications, tapering of immunotherapeutic medications, or spontaneously as part of the natural history of the disease. When severe, patients are at risk for life-threatening neuromuscular respiratory failure, referred to as a myasthenic crisis. Severe bulbar weakness that produces dysphagia and aspiration often complicates respiratory failure. Patients in myasthenic crisis typically experience increasing generalized weakness as a warning, although occasionally a patient will present with respiratory insufficiency at a proportion to their limb or bulbar weakness. Management of myasthenic crisis. Admit to the intensive care unit. Measure vital capacity frequently, as often as every 2 hours, if the respiratory status is deteriorating. Consider elective intubation based on overall clinical status, particularly in the presence of any of the following conditions. Declines in serial measures of vital capacity below 15 to 20 milliliters per kilogram ideal body weight. Declines in serial measurements of maximum inspiratory pressure less negative than negative 25 to negative 30 centimeters of the water column, that is 0 to negative 30 centimeters of the water column. Clinical signs of respiratory distress. Evidence of progressive respiratory acidosis. Difficulty handling oral secretions. Withdraw anticholinesterase medications to avoid excess airway secretions for patients who are intubated. Seek and treat any precipitating or contributing factors, particularly infections. Begin rapid therapy with plasma exchange or intravenous immune globulin. Begin immunomodulating therapy with high-dose glucocorticoids, for example, prednisone, 60 to 80 milligrams per day. Consider azathioprine, mycophenolate mofetil, or cyclosporin if glucocorticoids are contraindicated or previously ineffective. After starting plasma exchange or intravenous immune globulin treatment, consider weaning from mechanical ventilation when respiratory muscle strength is improving. For example, vital capacity of more than 15 to 20 milliliter per kilogram and maximum inspiratory pressure more negative than negative 25 to negative 30 centimeters of water column in patients with an adequate cough and manageable respiratory secretions. That's all for the video. We'll see you next time.